Assalamu alaikum. Good afternoon, everyone. We'll try to give 5 more minutes for just to see if there is any more attendees, and then we'll start the presentations.
Okay, Walid, I think we can start now.
طيب بسم الله الرحمن الرحيم. I would like to welcome every one of you to the beginning of our academic activity. Inshallah, for the new ones, we'll be having weekly academic activity every Thursday. I'll be the moderator for this session. Just few pointers and changes to the activity to the people from previous years. After each presentation, we'll be having two things. We'll be having a survey that is directed there is a feedback that the presenter will be using to improve their further presentations. This feedback will only be sent to the presenter privately. The second thing, after each topic, we'll be having regular questions. They will be appearing as a form of pop-up at the end of the presentation and Zoom. Last point, and I would like for all of you to participate in these questions. At the end of the quiz, we'll have a discussion, small discussion, run by the moderator usually. And all the answers are going to be anonymous. Last thing, I would like every one of you so this is the new form of attendance. Please write your full names in the chat, and depending on that, we'll be counting your attendance. I'll try to remind everyone during every presentation to write their names. And last point, our chief resident worked hard to try to improve our meetings. Our meetings are virtual, and these are not really conducive to a lot of participation and learning, but they help due to the presence of our residency programs all over the kingdom. So the focus, if you notice, a lot of the things that we'll be implementing throughout this year is a strong focus on active participation. Anyway, by that, I would like to start. And the first lecture today will be given by Dr. Yusuf Al-Alayani, and the topic is wound healing. تفضل يوسف.
Thank you, Walid. Thank you, Walid, for the presentation. I hope everyone gets it. And anyone can stop me at any point if you want, if you have any questions. Just to make sure, Walid, the lecture is there, right? The presentation is there. You can see it.
Yes, you can start.
Okay, thank you. Good afternoon. This is Dr. Yusuf. I will present the topic of wound healing. We will cover a few subtopics, including what is wound healing as a definition, what is it in terms of steps. Then we will go and we will study some key features about abnormal wound healing. Then we will talk a little bit about how wound healings can happen, whether it's primarily, secondarily. We will then touch the acute and chronic, and then we will touch on some adjuncts to wound therapy. Okay. First, we have to know what is a wound. A wound is basically a process in which structural integrity and a normal function are breached with a normal tissue, so that normal tissue no longer have its normal structural integrity. And the attempt to restore this integrity, the attempts to restore blood flow, the attempts to restore the nutrients to that previously injured part is called or termed wound repair or wound healing. We'll go through some of the points in details, and some we will touch lightly. Here, I just wanted to emphasize the differences when we say wounds versus when we say ulcers. Wounds is a breach in the continuity of said tissue. It's just the beginning of the breach. While ulcers, usually, whenever we say ulcers, we refer to the persistent breach of said skin or mucous membrane or tissue in general. And that's why ulcers tend to have stagings, whether it's pressure sores, whether it's diabetic ulcers or whatever ulcers. We have to stage it because we know it's just getting worse if it's not taken care of. For wounds, usually the driving factor or the driving stimulus is coming from outside, external, like blunt trauma or sharp trauma, or even burns. As for ulcers, usually the driving stimulus is interior, like venous hypertension, arterial misdemand, as in diabetic ulcers, and so on. For wounds, usually they tend to be acute, though they can be chronic in certain situations, while ulcers usually are the result of a chronic issue, chronic problem. That's why we rarely hear about chronic wounds, because usually chronic wounds are termed ulcers. So in general, ulcers are types of wound. If we can characterize them under wounds, but they usually refer to the chronic feature of wounds. So phases of wound healing, we will cover the three main phases. I think we're all familiar with these phases. We have the first one, we have the inflammatory phase, which includes the hemostasis and the actual inflammatory response. This usually takes up to 1 week. Then we go over the proliferative phase, which usually takes up to less than 1 month. And then we will go over the maturation and remodeling phase, which more or less takes usually or starts usually within 1 month, and then it can persist for a very long time. So this is what we said before. We will touch on all these steps one by one, and we'll talk about the important points regarding each one. The inflammatory phase. This phase usually takes, as we said, almost up to 1 week from the insult or the injury. The aim or the target from this phase is to limit the damage as much as possible by first initiate hemostasis, and then eat away the debris and removing the dead tissue, removing the microorganism debris. And this also, the inflammatory phase has multiple phases under it. It's not just one thing. So the inflammatory phase has 4 main stages: vasoconstriction, coagulation, vasodilation, and cell recruitment or cell migration. We will first start with the vasoconstriction. Vasoconstriction, this is naturally the first step. And this one is usually it's the first response to injury. And with this step, prostaglandin is released from the already injured endothelial cells. And the aim, just like it sounds, just constrict the vessels. We want to prevent any more bleeding to come in or seep into the wound. We want to not only stop the bleeding, but also subsequently stop the infections. Once you have more pooling of blood, you naturally have more infections. So that's the aim of it. These steps usually take about a maximum of 15 minutes post-injury. And as we said, it keeps the wound, it gives it its sterile baseline and clean baseline. And as we said, most importantly, aims to stop the bleeding. The second thing is coagulation. And now we already have the vasoconstriction. Now we have to have a way of permanently sealing the wound. So for this, the main component here are 2 things: the collagen type 1 and platelets. The collagen type 1 that is already exposed merge, if we can say, or fuse with the platelets. And this fusion of both, they form what's called fibrin-platelet matrix. This fibrin-platelet matrix initiate the coagulation cascade. It attracts chemoattractants. And the chemoattractants released from this fibrin-platelet matrix can produce many glycoproteins, fibronectin, fibrinogen, van Willebrand factors. And as these platelets aggregate and the clotting factors released, this result in the almost like a mesh-like around the wound. So you have a clot and you have a mesh that hold the clot together. And both of these steps, they form the hemostatic step, which is the most important step. And the other steps behind it or after it will not be proceeding naturally if this one did not take place. So this is what we mentioned before. As we can see at the top left, we have the platelets, we have the fibrin or the collagen type 1, it's merged together that initiate the chemoattractants to release the glycoproteins. Glycoprotein help with the initiation of thrombin, thrombogen, and fibronectin and van Willebrand. This will cause or will put the mesh around the fibrin platelet matrix, and this will seal the wound and will have the wound ready for the next step, which is vasodilatation and cell migration. Now that the wound is closed and the bleeding stopped, now we have to bring in nutrients. Now we have to bring in the inflammatory response. Now we have to bring in the recruits to fight off the infections. And once the hemostatic steps pave the way, as we said, the recruits show up at the site of the injury, and with the help of vasodilation, the nutrition comes in, neutrophils, polymorphs, lymphocytes, they all rush into the injury and they cause tissue edema, which is what we want. We want a degree of edema around the wound to help fight off the infections. The neutrophils and polymorphs and lymphocytes, they're all stimulated by other components, which are serotonins, kinins, histamines. All of these components are made up of already broken down tissue. And of course, bacterial products. The inflammatory cytokines, mediators like platelet-derived growth factors and insulin growth factor and necrotic tumor necrosis factor and interleukins, especially 1 and 6, they attract granulocytes. They attract fibroblasts to the site of injury. And the role of fibroblasts, we will know it later on, as it's very important, not necessarily here, but later on, it's very important. It helps with the formation of the collagen and the production of collagen, actually. While the neutrophils here, they start phagocytosing the debris and the bacterial and the organism tissue. The last step of the cell migration are the macrophages, and they are almost the most important and the one that will last up to the end. They last usually from 24 to 48 hours, and their job is to eliminate already dead cells, and they help polymorphs to undergo apoptosis because their job is finished. So they have to go, and macrophages have to take place. And as I said, they are the last force, if we can say that, stay in the wound and fight off the infection and take out the debris or the rest of the debris that is still there, that was not taken by the previous cells. Remember that there are many more factors to cell migration. I just mentioned the key components of those, but we still have much more components to the wound healing and cell migration. So this picture basically summarize what we said. On the left side, if you can see, we start with vasoconstriction, right? So we have the vasoconstriction, we have the clot formation, we have thromboxane, we have the plug formation, and on the right side, we have vasodilation. Vasodilation, by the way, takes place almost simultaneously, right after the vasoconstriction. And we can see histamines, kinins, interleukins, 1 and 6, basically mostly helps bring in the macrophages, lymphocytes, and neutrophils to fight off the infection. And with this, the inflammatory response has now taken place. The dead tissue is already out. The infection is to a degree limited. Now we have to build in, or now we have to rebuild the already damaged tissue. So that's where the proliferative phase takes place. We have angiogenesis, fibroplasia, epithelialization. All of these are very important steps to take over and build what was already damaged. The damaging factor is already ended by inflammatory response, and the initiation of or building of new tissue starts with the proliferative phase. We will talk about each one of these in separate. So proliferative phase, as we said, have 3 main components. We have the matrix formation, we have the angiogenesis, and we have the epithelialization. Matrix formation, which mainly takes place by fibroblasts, the ones that we mentioned before. Fibroblasts, they start coming in the wound in a semi or almost undifferentiated cells. And at that stage, they produce collagen type 1. And as the infection goes away or already defeated, the fibroblast no longer needed at its form and differentiate. It has to differentiate and turns into something else. As it turns from undifferentiated to differentiated, it releases collagen type 1. And it keeps releasing collagen type 1, and this usually takes maybe 3 to 5 days post-injury. By the 5th day, usually the fibroblasts are already almost all differentiated. The period between the initiation of differentiation until the complete resolution of undifferentiation is called lag phase. So lag phase basically means, if we can define it in another way, the phase in which collagen type 1 is being produced. By the end of it, it's gone. It's stopped. And why it stopped? Because the fibroblasts now here, they, as we said, differentiated into something else called myofibroblast. And this myofibroblast is basically just fibroblasts plus actin bundles or muscle tissue. And we want that. We want that muscle tissue because we need the wound to contract. We need the wound to have some kind of tensile strength. So basically, the strength of the wound starts with wound contraction, and that usually takes place around 7th to 8th or 9th day of the injury. Now, collagen, as we said, the synthesis almost stops, and after 4 weeks, it's almost completely resolute. It completely stops, and the degradation of collagen type 1 starts, and the rate of genesis of collagen is met with the degradation of collagen. And usually this happens by a lot of proteases, but mainly happens by the matrix metalloproteases, which basically start breaking down this collagen. And this is a phase we will talk about later. It's called collagen maturation. It's a part of collagen maturation, actually, not just the only step. Okay, so now we have reached angiogenesis. Now we have to bring in more blood vessel to the tissue. And this is very important step, and usually triggered by the hypoxia level or the low pH level around the wound. The wound itself, the pH level, the lactate level is different than the surrounding tissue. So that difference, if we can say, is the one that drives the angiogenesis to start. The angiogenesis has to start. We have to have cells, and we have to have them arranged. And the molecule very important for that. It's called PECAM, platelet endothelial cell adhesion molecule. This one is very important molecule because not only does it help with cell-to-cell adhesion, but it's the molecule that helps the vessel to take place, take a tube-like shape. And the cells start to aggregate one next to the other, but by the end, we need these spaces to be as tight as possible. We want a good, healthy blood vessel. That's why we have beta-1 integrin receptors. These receptors help bring in the cells together, bring in the endothelial cells together, and this is the way we start with angiogenesis. Angiogenesis, it's not really accurate if we just say angiogenesis. It's just new vascularization, and we have two ways of these. I think most of us already know. We have angiogenesis versus vasculogenesis. Angiogenesis just basically means forming new blood vessels from already existing damaged vessels, and this can happen with a lot of molecules, but mainly it happens with vascular endothelial growth factors and transforming growth factors to a large degree nitrous oxide. As for the vasculogenesis, just basically means we have to start from the ground up. We have to start from zero. So you need some sort of sub-stem cells, if you can call it that, and that's the endothelial progenitor cells. Now, which vessel will turn into arteriole, which one will turn to a venuole? This is mainly derived or determined by the kinase domain containing receptor, KDR. This receptor is the one that will help send more nutrients and more muscle tissue or protein towards one blood vessel, making it an arteriole, and less toward the other one, making it a venuole. And it's the one, and there is a ratio. Of course, I did not mention it here because we did not want to go into much details, but there is a ratio of how many arterioles for how many venules. This picture just shows what we said before. We will leave it. I already explained most of this part before. Now we reach almost to the end of wound healing. That is the epithelialization. So this stage usually takes place within hours after the, not necessarily the injury, but after the blood clot formation. It involves a series of cells. It involves the detachment of already existing cells, migration, proliferation, and differentiation. And the epithelialization usually starts a bit slowly, and then it picks up speed. The cells usually here are stimulated to migrate and attach to neighboring cells and adjoining cells to the dermis. Basically, just to summarize the slide, because some of you may read it and might find themselves confused. Basically, the epithelialization, it doesn't just refer to making new cells. The tissue here brings in cells from other parts, loosening the joints from other parts, and then bringing it to the base of the wound. And you start from down to up. That's why it's called leapfrog. You start from the base of the wound and works its way up more towards the edges and less towards the center. And this basically just summarizes epithelialization. Okay, after the wound becomes completely epithelialized, the cell become stratified again. They firmly attach to one another, as we said before. After they loosened from other place, now they have to reattach strongly to the side of the injured part. And as it heals, as you can see the picture from the left side, as it heals from the down up, naturally more towards the edges, the old tissue that is forming layer by one layer. It gets pushed up until it's end in a scab. Scab, not scar, that's very different. Scab. Then the scab itself, by time it gets detached, leaving the scar behind it. This is the last stage of wound healing, the maturation phase. And this usually, as we said before, usually takes or starts usually around 1 month. And at this stage, if you remember before, we said collagen reached a peak in which the production of new collagen is so low that is almost equated by the amount of collagen being destructed. So in this maturation phase, we don't need more collagen. We just need another way of collagen or another molecule of collagen called or the already existing type 3 that was low to begin with is now replaced with more of type 1. And the maturation phase refers not just to the change of the molecule, but also to the cross-linkings of the molecule. And with this, we have more and more granular tissue. And it's finally, as we said, as it's mature at the end, it leaves the scar tissue. So this step includes the merging of small vasculature, of course, because now we have more tissue and bigger tissue. Before we had smaller tissue and we need very small blood vessels. Now we have bigger bulks of tissue. So you need bigger blood vessels. So the already existing smaller venules and arterioles, they merge together. They make a bigger blood vessels, whether it's arteries or veins. And now they have to supply a bigger chunk or bigger bulk of tissue. And by the end of this, or referring to what I just mentioned, this is what's called remodeling phase, which is mainly collagen-derived and scar-ended stage. Now, at the first week, because we had very few collagen molecules, the wound has 3% of its normal breaking strength. At 3 weeks, we reached almost 30%. At 3 months, actually not 3 months, but almost 100 days, this is where the wound becomes at its peak strength, at 70 to 80%. Now, just one thing to know here is that the tissue or the injured tissue, even after it heals, it could never reach the same amount of strength that is exerted by normal tissue around it. The injured tissue will always have a degree of weakness. And if that injured tissue became injured again, it will exert itself and it will become even weaker with time. So the normal tissue, the non-injured tissue will always be stronger. So this is what we said in short, the hemostasis, the inflammation, the wound healing with the proliferation, and we have the remodeling at the end. Remember that we left a lot of details. We just mentioned the ones that I thought maybe are important and the key players in this. So if you need, you have to read more about it. But I think we mentioned just the key players in this, the very important ones that we really need to know regarding wound healing. So we'll talk about now abnormal wound healing. We talked about what's normal. We have to know what's abnormal. In such a complex series of interweaving events, wound healing and many factors can be the outcome. The amount of tissue loss or damage, the amount of foreign material, bacterial inoculation, and the length of exposure, toxic factors, intrinsic factors such as age, chemotherapeutic agents. Basically, from the slide, what we want to know is that the steps that we mentioned before, if it's tipped off one way or the other, if something happened, if one of these steps got either interrupted or abnormally happened, usually we end up with one of two things. You either end up with keloids or hypertrophic scars. And both are bad, but we will know some differences. We will know why, if anything, you don't want to end up with keloids. Keloids are basically type 1 and type 3 collagen fibers. And it's a very disorganized matter, very, very disorganized. If you compare it with hypertrophic scars, keloids usually are thicker with abundant collagen bundles. And as we said, it's very disorganized. They tend to grow beyond the borders of the original wound, and rarely do they regress. By that I mean they break down. They either continue growing or they will stop. But it's almost never do they never regress on their own, unless there is a factor, which is very, very rare. The very cause of this is not known, at least not in great details, but we have proposed theories. One of them includes any abnormal in the apoptosis process, or mitogen activated protein kinase, or tumor growth factors, or interleukin 6 and 1, plasminogen also play a role. These processes or these molecules are all normal, but once they undergo any abnormal process, whether it's concentration, timing, they can lead to keloids formation, not only co-formation, but also progression, which is very important. There's an evidence suggesting genetic accessibility. That's why they usually tend to run in twins, and most of the time they are seen in autosomal dominant fashion. They can take place anywhere in the body, but usually they tend to accumulate on the trunk, upper extremities, on the face. And they are usually refractory to medical or surgical intervention. By refractory, that means if you remove them, they will grow up again. Even if you went very deep and you took unless you have to take the whole tissue around them, but usually they will regrow again. This is a picture of a keloid. Now, as you can see, I'm sure you can't see the original wound, but it's clearly they are growing way beyond the border of any imagined wound. They are thick, abundant, and they can grow. They don't have a specific pattern, by the way. They can grow anywhere in the face, in the trunk, in the upper body. On the other hand, hypertrophic scars are much more benign, if you can use that word. Is mainly type 3 collagen and more organized. They tend to grow within the confines of the original wound. They don't grow out, outward. They tend to grow upward. And they usually, whenever you stop the stimulus that causes them to progress, if that stimulus is halted, they will regress spontaneously. And they tend to be more preventable, more easy to deal with. They usually need a long time to happen. They need a long time for them to actually initiate happening. And one of these things that tend to leave a longer effect are chronic wounds or ulcers. And on top of those are burn wounds. They're very common after burn wounds. So this is an example of hypertrophic scars. I think these pictures are almost perfect description of hypertrophic scars, but even if you Googled some of the other pictures, they almost look like this. Very linear. They don't grow, at least ugly, beyond the, or outwardly beyond the wound confines. And if you remove them, they tend not to grow again unless the stimulus is still there. Naturally, they will grow back. So we'll talk about about the types of wound healing. We'll cover primary, secondary, delayed, or tertiary. Primary, I think it's very easy. We all know what primary is. That's when you see a small, clean wound, usually done by a blade, perfect cut, clean cut. And the idea of primary intention or primary union is that you go in and you close the wound in a sterile fashion. That will leave very, very good looking scar, if any scar at all. The wound will heal nicely and cleanly, as long as the way you close the wound is sterile. This is primary intention, and basically means you went in and you closed it yourself. You did not leave it open, which is the issue with the secondary union or secondary intention. You have to leave it open, and this is usually happens with the secondary is when you have a large defect or larger wounds that you can't just close it. It will just either get infected or just accumulate fluids underneath, and because you leave it or you just follow it and wait for it to heal by itself, it usually leaves an ugly scar. And the secondary intention usually are chronic wounds. They need to be followed up for longer periods of time. If you happen to see a secondary wound, and then let's say that wound start healing nicely, and you went in and you close it yourself, that's what we call tertiary intention. Tertiary intention basically means you saw a wound and you maybe had a plan to leave it open, secondary, and then started healing nicely. It left a nice layer of granulation tissue. You went in and you closed it yourself. So that's why it's called delayed primary. Primary meaning you closed it, delayed because you did not close it at the beginning. This usually happens when we plan to leave a wound open, secondarily, as we mentioned, but then throughout the time, the wound start nicely healing, and maybe you were afraid that, for example, a patient is not taking care of himself hygienically, or a patient is far away and they don't have any peripheral hospitals, so you're afraid that no one is going to follow up on his wound. So we take the chance, you go in, you close it. That's what we call tertiary intention. Classification of wounds. This we will touch very lightly on this subject because I think I already mentioned some of it in the beginning. Acute wounds, and we have chronic wounds. Acute wounds usually are a result of direct trauma. This is traumatic injury, whether it's missile injury, velocity like bullets, lacerations, avulsions, crush injuries, and abrasions. These wounds tend to happen very quickly. They don't need longer time to happen. And when we define acute or chronic, we're not necessarily referring to how we stitch them or close them. Just acute and chronic based on how long did it take for that wound to be called a wound. Chronic wounds, we mentioned these before, they tend to be called ulcers. And they usually, caused by metabolic disorders rather than external injuries. And they can be venous or diabetic ulcers or pressure ulcers, arterial like diabetic, of course. And these ones, as we mentioned before, they take longer time to heal, and usually they take more than one step to help healing them. Then we go to category of wounds. First, we had something called surgical wound classification. This was, I think, back in the 50s or 60s, and it was done to classify wounds. Then the CDC came in and they refined the definition of that surgical wound classification and refined it based on the bacterial load on a surgical field. And they had to divide wounds on the expectation that the wound will either way undergo SSI or surgical site infections. So they had to divide them into 4 categories. The first one called clean wounds. And clean wounds, these are the wounds, first of all, these wounds tend to be small. And whenever we say clean, we mean the entry to that wound is clean and the closure of the wound is also clean. So you go in a very sterile manner, you do the procedure and you go out and close the skin in very, very sterile manner. And this one, the perfect example of these are biopsies. Thyroidectomies also to a degree are considered clean ones. But biopsies, even excisional biopsies, even if they were big, as an excisional biopsy, you still go in cleanly and close it in a very sterile manner. That's what we call clean ones. Second one, we have what's called clean contaminated. By the way, the red number next to each title is the percentage of surgical site infection that could occur. So clean wounds 1 to 5, and this one up to maybe 10%. Clean contaminated. Clean contaminated means that the entry in the wound was very sterile, but you are working in an environment that tends to have secretions. And these usually, whenever we say that, we're either talking about respiratory, alimentary, GI, or genital or urinary tracts. So usually in these environments, they are clean, you have to expect some sort of contamination, but there's no significant spillage. So no significant secretions. Then we have contaminated. This one have up to almost 20% chance of having a surgical site infections. And these usually, there is a breach and the sterile technique, or as we said before, an increase in the spillage. And usually this happens whenever you work in a GI tract or urinary tract or respiratory tract. And usually in this, what makes this different than the worst one, the infected, is that we don't have enough purulence or purulent materials to be called infected or dirty. And that's number 4, infected. These are when the entry of the wound is dirty in general. And this usually happens from the ones that we mentioned before, traumatic injuries, acute traumatic injuries, bullets, missiles, even lacerations to a degree. You have a wound that is infected. You don't expect that wound to heal by itself. Definitely sterilizing that wound will take more than one step and usually need surgical intervention to help healing that wound. This slide, I just wanted to mention some things that will aid in healing of that wound. Of course, there are many, many more than these in this one, but this is just to give us an idea about how we can help. For example, vitamin A depends on the dose, can enhance immune response. Protein intake, the more protein you take, it helps, as we all know, in the inflammatory response. Vitamin C, vitamin A, zinc definitely helps a lot. So this is just a slide that will show what we can do, but you need to consume these on a regular basis. You can't wait until you have a wound and then start eating them. Now we have to add adjuncts other than food or other than dietary that help with wound healing. Dressing is for this is very basic. Whenever you have a barrier that helps seal the wound from the outside environment, there you go. You just prevented, you helped the wound to heal by itself. Negative pressure wound therapy, it's not something that we usually use here, but the idea is you put some sort of a vacuum that will pull in or absorbs as much tissue, tissue edema as possible. If you reduce the edema, you reduce the bacterial contamination, and you promote more and more wound healing. But this generally is not used a lot, especially in any wound that we expect or we want fluid to flow in freely. Like whenever you work on your blood vessels, you don't want a vacuum pressure because it will pull the fluids outside of the vessels, and you will just have poor circulation there. And if you have a freshly anastomosed blood vessels, that's definitely not indicated. Hyperbaric oxygen therapy, this is not something new, of course. It is very old modality of treatment. And as we all know, it's just the idea of hyperbaric oxygen is you concentrate oxygen in a very specific place. The idea behind it, the more you concentrate oxygen, you will have more vasoconstriction, and vasoconstriction equals increased arterial oxygen pressure, stimulation of angiogenesis, fibroblast proliferation, the steps we talked before. However, you don't want to use hyperbaric oxygen therapy in places where you don't want the arterial to constrict, or you don't want increased arterial pressure, like in case of congestive heart failure. But it's been used, not necessarily cardiac surgery, but it's been used almost in any other wound that is expected to heal in a very long time, like fistulas and necrotizing fasciitis. Factors delaying wound healings. We can talk in a full lecture about just this subject. It's way too many, but in general, I just divided them to make them easier into local and systemic. Local, like infections, the persistent of a foreign body. Let's say there's a bullet still in the same wound. Of course, we don't expect it to heal nicely. Poor oxygenation and venous insufficiency. Systemic are almost endless. Age, stress, steroid smoking, AIDS, immunosuppressive therapy, malnutrition, sepsis, and there's some degree of inherited diseases, of course, progeria, Werner syndrome, all these, each one of these diseases, we don't want to get into too much details about this, but there are a lot of diseases that affect either one or two or even more steps of the steps that we mentioned before, whether it's angiogenesis or cell migration or whatever. So these diseases, they tend to slow down, if not halt, the healing process. One important subject is moisture balance. We have talked before about moisture. Moisture is very important. It promotes granulation tissue, angiogenesis, epithelialization. The idea is to have moist. That's why we said balance. You want moisture in there, but you want balance. You don't want too many secretions. Whenever we say moisture, either the serous fluids that the body is secreting, that is good to help the wound healing, or, for example, externally, like when you use saline, for example, to help irrigate the wound. It's very, very, very important, given the fact you're not overdoing it or the body is not producing too much serous, because that would halt and probably it will even cause pooling. Pooling equals stagnation, and that equals more infection chances. So when managing wounds clinically, it's important to remember that each is different and will have different requirements. Nonetheless, a useful model to guide general moisture management is based on the principal aims of promoting moist environment for healing while managing the detrimental effects of excess exudation. This is just exactly what I said before. So in this regard, most wounds dressing are used generally categorized according to their effect on the moisture. We can use hydrogels, we can use normal salines. As we said, moisture is a good thing, given the fact we're not overusing it, and it doesn't have to be externally added. The body itself will, that serous fluid that we said, it does help wash away debris and aim more towards genesis of new blood vessels. This is the last subject of today. That is the edge of wound, or the edges of wound in general. Healthy edges promote migration of epithelial cells to form to form an epithelialization layer. An unhealthy edge can occur when there is a failure of migration, or when there's tissue beneath the wound edge is destroyed or broken down. What we sometimes term to undermining. I apologize, I failed to add a picture of undermining. Undermining basically means when the skin or the edges, I want you to imagine the edges of the wound having either dead tissue underneath it, or the tissue is already eroded. You don't have any more tissue down there. So it's just a skin, flopping skin with nothing underneath it. The failure of migration can be caused by inadequate debridement, a failure of cessation of inflammation, as in consistently high protease levels, because these, as we know, these broke down more cells, and we want the proteases, but we don't want them in the whole process. We just needed them, if you remember, at the inflammatory phase, and to some degree in the maturation phase. But after that, we don't want more proteases. We don't want more enzymes to break down the cells. We need more cells. So and more chronic wounds by fibroblast and epithelial cells becoming senescent. I mentioned before, if you remember the inflammatory phase, cells do their part and then they have to undergo apoptosis. If they became immortal, if they became alive and not either migrating or not dividing, they are more of an issue. They don't help. So we need these cells to die or die off, or just to migrate to the side of tissue and help aid in the tissue or wound healing. Cells that remain at the edge and do not migrate can become hyperproliferative, leading to appearance of a hypertrophic wound, or having a closed edge. Problematic edges that impede the healing process may require surgical evaluation and department and skin, or even skin grafting. So just like I said, we need that rolling, we need that migration to happen. If you have any tissue at the edges of the wound, but it's not either senescent, as we mentioned, or it's dead tissue, you can't imagine that wound to heal nicely. And with this, we finished today's lecture. I apologize if I took too long. I tried to just mention the basics of wound healing. I include some references here for anyone who wants to read in details. I just try to mention and bring in the key factors or key notes regarding wound healing. I will stop here for any questions. Walid, if you have any, want to intervene or ask any questions, I'm ready. Thank you.
يعطيك العافية يوسف. Excellent, very thorough presentation. We'll begin now by the first quiz, but before I begin with the first quiz, just notice something. I've noted that a lot of the attendee, their names, they don't have their full name. Some of them have iPhone or some numbers, or maybe just the first name. Please just make sure that you have your full name showing or appearing in the Zoom, as this will also count into the electronic automatic attendance. Now we'll begin the first quiz. I'll give you a minute or two to finish the whole quiz and then we'll discuss it. Is anyone finding any difficulty finding the quiz or trying to answering it? Salam. طيب, I gave you 3 minutes just to see 50% participation, which is excellent for the first time implement of such a tool. Uh, okay, so I'll begin discussing the questions. So the first question was steroids impair wound healing by which of the following? Decreased angiogenesis and this is a form of answers that so basically here we're asking steroids does it impair wound healing by which يعني by affecting which stage of the wound healing that Yusuf stated, but instead of bringing you the name of the stages, we give you the explanation for stages. So usually steroids affect the wound healing by affecting the inflammatory phase of wound healing. And if you remember from Yusuf can you remind us what is the inflammatory, يعني the big events that happen during inflammatory phase? Is my voice clear?
Yes, Waleed, can you hear me?
Yeah, I can hear.
So inflammatory phase, whenever we say inflammatory phase, we refer to either the beginning of the hemostasis phase. So we have the angiogenesis, we have the coagulation and clot formation, and then after that we have the this vasoconstriction and the dilation cell migration, right? So the steroids naturally they are anti-inflammatory. They will work on this process halting at its place. That's why people that take steroids or have autoimmune already, we expect this to have some sort of an issue with this process.
Excellent. Well done. So as he stated before, the hallmark of some of the most important events that happen during inflammatory phase is the angiogenesis and the neutrophil macrophage migration. So that's the explanation for the first answer, and the first answer is A. The second question is how does diabetes mellitus impair wound healing? This was the question that a lot of people had differing answers on, which is interesting. So, but the majority landed on A or B. Uh, again, diabetes. I'm sure you all know the effects of diabetes on the microvasculature. Therefore, diabetes affect these vessels and it reduces the local ability of angiogenesis and inflammation due to the vascular disease that it leads to. The last question is basically just a memorization question. This is common question in a lot of books, pathology books and exams, and if you go to GS books as well. Just memorization. Which type of collagen is most important in wound healing? It's usually type 3, and a lot of people, mashallah, answered correctly. Last question is the proliferative phase of wound healing. Usually the proliferative phase lasts between 4 to 12 days. Therefore, it's the answer is 7 days. Just one point about the first question, the steroids. Since the steroid usually affect the inflammatory phase, one clinical point, usually the use of steroids beyond this point of the inflammatory phase, which is the first 5 days or 6 days, the effect of it on wound healing is much less notable than using steroids in the first 3 days. Anyway, that's it for the questions. I just saw that Dr. Farid joined us in our activity. I would like to welcome him. And Dr. Farid, if you have any feedback or questions to the presenter or to the audience regarding the first topic.
Assalamu alaikum. I apologize. I also joined late, but the topics are very interesting, very important for the basic science part of your training. I sent you a comment. I'm not sure if you have received it. Were these questions shared with the presenter before, and did he allude to those points to reinforce it? I think it would be a good strategy, learning strategy, that the presenter should also be aware of the questions and try to illustrate those in his slide, not necessarily put it as a question and answer, but to raise the point. I'm very happy to see you guys again gathering for this afternoon teaching. I'll try to attend most of them, and I wish you all the good luck. Thank you.
يعطيك العافية دكتور خوجن. We'll try to implement this. These we'll try to send the questions to the. Usually the questions are done by the moderator, but we'll try to arrange between the moderator and the presenter in future lectures. But I just have one question. Do you see the statistics of the question answered? The rest of the group. Are you able to see who participated, the percentage of questions? Because I'm sharing the results now with you. Okay, so if you're not able to see the
If you're showing anything, I can't see it. So
وليد لا أنت بس احنا نقدر نشوف النتائج الإجابة حقتي
اوكي خلاص excellent.
الحين أقدر أشوف
طيب.
إيه
ممتاز. طيب, now we'll just be sending the survey and then we'll give please do the survey as this will help the presenter in improving his presentation. After that, we'll take a break of around 5 minutes and then we'll come back with the next topic. السلام عليكم دكتور سالم، جاهز؟
ايوه جاهز.
تبغى تسوي شير؟
صوتي واضح؟
يعطيك العافية. تقدر تبدأ دكتور سالم متى ما جهزت.
جاهز يلا.
يلا العافية.
السلام عليكم. My name is Salim Tawfiq Rasmi, and today I will talk about the food light imbalance management. I will start with the sodium. The normal level of sodium are between 136 and 145, and hypernatremia is defined as a serum sodium is more than 145. And the clinical feature is classified according the onset. Acute hypernatremia is the sodium rising in a period less than 48 hours. And the symptoms for the mild hypernatremia is sign of dehydration, starvation, decreased and the skin moderate symptom is confusion, irritability, and lethargy, muscle weakness, and reflexia. Severe symptoms typically occur when the severe hypernatremia reach up to more than 160. And the symptoms will be the focal neurological deficit, congenital. Chronic hypernatremia is the onset occur for more than 48 hours, and the symptoms non-specific and be mild symptoms. And it will be dehydrated. It will be the management has a hypovolemic. If the patient has a hypovolemia, so if it is a severe hypovolemia, we'll start restoral eovolemia with normal saline before correcting hypernatremia. If the patient has a mild to moderate depletion, we will manage both the volume and the hypernatremia at the same time. And we need to identify hyponatremic, and we need to do a hyponatremic correction. If the patient severe impairment or refractory fluid overload, we can consider hemodialysis, and we need to restrict the sodium level to be less to management hypernatremia. First, we need to replace deficit orally with the water IV by pipe water. We need to calculate first the total body water, and we can calculate that by multiply K factor by his weight. K factor in male is 6 and in female 5.5. And then we calculate the free water deficit. We multiply the total body water, serum sodium concentration divided by 150 minus 1. And we can calculate it easy by the medical to estimate the ongoing free water loss by input chart, and we need to correct the hypernatremia in the acute hypernatremia over 24 hours, and in chronic over 48 hours to 72 hours. We need to do every 1 to 2 hour serum sodium, and every 4 hour, every 4 to 6 hour in chronic hypernatremia. The complication of hypernatremia is or osmotic demyelination syndrome. The complication of hypernatremia treatment, rapid correction of sodium, cerebral edema, and hypervolemia secondary to hypernatremia correction. To identify the underlying cause of hypernatremia, first we need the urine osmolarity. If the urine is more than 600, this is imply X-ray, and then we look to the patient status. Is he hypovolemic? This is GI loss, osmotic diarrhea, or vomiting, or NG tube suction, or skin loss, or febrile illness, or excessive sweating. Or if the patient eovolemia, this is impaired thirst, like in hypothalamic lesion, or dementia, lack of access to water, like a ventilated patient, or immobile, empty. If the patient hypervolemic, this is iatrogenic by hypertonic fluid, or TBN, or ingestion of salt water. If the urine osmolarity more than 100, this is a renal mechanism. If the patient hypovolemic, this is a diuretic or osmotic diuresis, or diabetes insipidus. If the patient eovolemic, this is diabetes insipidus. If the patient is hypervolemic, this is a con or hyponatremia. That the sodium is less than 135, and it classifies according to the severity, mild hyponatremia.
دكتور سالم. دكتور سالم.
الو الو
يس دكتور سالم.
صوتي واضح؟
صوتك قطع دكتور، هو البرزنتيشن برضو قفل.
الحين صوتي واضح؟
اي دحين واضح، بس البرزنتيشن مو طالع لنا. اي ممتاز.
كده واضح.
اي
أنا وقفت عند أحد سلايد صح؟ الو
هي دكتور كمل.
تمام، صوتي واضح الحين صح؟
اي يعطيك العافية.
Moderate hyponatremia is the level of sodium is 125 to 102, and severe hyponatremia is less than 120. And disease onset to the acute hyponatremia and chronic hyponatremia, and also to the plasma osmolarity, hypotonic or hypertonic or isotonic. Symptoms is anorexia, nausea and vomiting, headache, confusion, and seizure, and ataxia, respiratory failure. Hyponatremia, first we will check it by the serum of sodium is less than 135, and we need to for the glucose and calculate the corrected level of sodium for hyperglycemia if the glucose level was high. If the hyponatremia is confirmed, then we look to the serum for that. If the serum of osmolarity more than 295, this is a hyperglycemia or IV mannitol or IV radio contrast. If normal osmolarity, this is isotonic hyponatremia, TUR syndrome, or pseudo-hyponatremia due to multiple myeloma. If low osmolarity, this is hypotonic hyponatremia. If it is an acute, severely symptomatic, then we will start correction by give hypotonic saline. If the patient is stable or it is not an acute, severely symptomatic, then we will look for the underlying etiology. We look for the urine osmolarity. If it is low, less than 100, this is primary polydipsia or low salt intake. If the ADH was high, this is ADH active. If the urine sodium low, this is extrarenal. If the patient hypervolemic, this is heart failure or liver cirrhosis, nephrotic syndrome. If the patient hypovolemic, this is a diarrhea or vomiting or third space or PER. If the renal sodium was high, this is if the patient also hypervolemic, this is a renal failure. If the patient eovolemic, SIADA or hypercortisone, if the patient hypovolemic, this is diuresis. Hyponatremia management, if the patient has an acute severely symptomatic, we'll start correction by giving 30% normal sodium chloride 10 ml over 10 minutes, and we can repeat it 2 times until the symptoms resolve. And we need to check the serum sodium every 20 minutes until the symptoms resolve. Our goal of correction is to achieve increase 6 milliequivalent in serum level in 6 hours. For the chronic hyponatremia, our goal to increase the serum level of sodium by 8 milliliters over 24 hours. And this is the equation for calculate the sodium correction hyperglycemia. Moving to the hyperkalemia, the normal potassium level is between 33.
يا دكتور برضه قطع مرة ثانية الصوت عندك. صوت والبرزنتيشن. هل في أي إمكانية إنه ممكن في شبكة ثانية تقدر تدخل عليها ولا شيء؟
للأسف. كذا
طيب،
احنا نشتغل ولا باقي؟
إيه الآن واضح.
طيب, the normal level of potassium is 3.5 to 5.5. Hyperkalemia defined that the serum potassium concentration of more 5.5. The causes, anything that decreases aldosterone, ACE or Arab spironolactone, digoxin, beta blocker, acidosis, and diabetic. The clinical feature, symptoms occur if the potassium level more than 7 or 6.5. The symptoms will be cardiac arrhythmia, muscle weakness, and paralysis. The diagnosis, electrolyte and kidney function, CBC, liver chemistry, and glucose, blood gas for metabolic acidosis, ECG finding. The tall, big T wave, and cardio or ventricular fibrillation. Hyperkalemia post-cardiac surgery, it occurred because the high potassium cardioplegia solution is in patient with renal dysfunction. The output status with oliguria can also lead to rapid increase in the potassium. Acute or chronic renal insufficiency also contribute to hyperkalemia. Medication like ACE, potassium sparing diuretic, beta blocker, and increase and impaired potassium excretion. Severe hyperglycemia lead to potassium release from the cell into the extracellular fluid. Acidosis worse the hypokalemia with a raise of 0.2, with the reduce in 0.2 in the pH will cause increased 1 milliequivalent shift in the serum potassium. In the hyperkalemia, first you need to check the level of potassium. If it is more than 4.4, this is a hyperkalemia. So we'll check if there is if there is a muscle weakness or paralysis or ECG change or the potassium level more than 6 or 6.5, this is considered an emergency and we need to be we will first we'll do continuous cardiac monitor. We give 10 milli of 100 milligram calcium gluconate over 2 to 3 minutes. The effect will last for 3 to 6 minutes. Within 5 minutes, ECG should be normalized. If not, we can repeat the calcium gluconate again. Intracellular shifting of potassium, we will give 5 milli of 50% dextrose with 15 of insulin. We can give inhaled short-acting beta agonist. And we can give sodium bicarb if the patient has a metabolic acidosis, and we consider hemodialysis for refractory hyperkalemia. Can give low diuretic with volume overload patient. For the hypokalemia, is defined as the serum potassium is less than 3.5, and the causes is anything that is aldosterone and corticosteroid, beta agonist, alkalosis, insulin, or diuretic therapy, GI loss, or low magnesium. The patient may be asymptomatic, may has weakness or cramp or decreased deep tendon reflexia or arrhythmia. The diagnosis also will do electrolyte and blood gases, urine potassium to narrow the diagnosis, and ECG finding. And we'll order ECG. The ECG finding, mild to moderate, hypokalemia, ST depression, and T-wave. Severe hypokalemia, the presence of U-wave and QT prolongation. Hypokalemia post-cardiac surgery is due to diuresis and insulin treatment for hypoglycemia and hypomagnesemia. Hypomagnesemia caused by diuresis can lead to refractory hypokalemia, and alkalosis, metabolic or respiratory. For hypokalemia, first, if the level of potassium between 3.5 to 4, and the patient is with a DKA or congestive heart failure, we look for BS. If the patient has a metabolic acidosis, we'll consider oral potassium bicarb, and we will give 25 milliequivalent BO every 6 to 12 hours. If the metabolic acidosis occur in this patient, we consider potassium chloride 10 to 40 milliequivalent BO every 12 to 24 hours. If the patient has 3 to 3.5, we'll consider to give intravenous potassium. We'll give 10 milliequivalent per hour until we reach our goal. If the patient has a potassium level below 2.5, we'll consider intravenous potassium through the central line. We'll give 40 milliequivalent IV per hour until
دكتور سالم، الاتصال فصل معك مرة ثانية.
معلش. كان صوتي واضح؟ طيب. If the potassium level is less than 2.5, we'll give intravenous potassium for the central line, 40 milliequivalent IV per hour until we reach, until the symptoms resolve or we got the serum level above 2.5. We need to treat underlying cause. We review the medication, and it can induce hypokalemia like lobe diuretic and thiazide should be stopped, discontinue or reduce the dose of potassium sparing diuretic. Will start oral or IV magnesium for patients with hypomagnesemia. We consider potassium replacement condition that has a high risk for reblation or refractory hypokalemia like DKA or high dose insulin. The normal level of calcium is 8.6 to moving to the hypercalcemia now. the normal level of calcium is 8.6 to 10.5. Hypercalcemia is a total of serum calcium concentration of more than 10.5. And ionized calcium is more than 5.25. The clinical feature will be renal stone, constipation, bone pain, abdominal pain, nausea and vomiting, cardiac arrhythmia, pancreatitis and polyuria and dehydration. We approach this if the serum calcium is increased, and we need to look for the ionized calcium, or we calculate the corrected calcium for serum albumin. If the calcium is increased, we look for parathyroid hormone. If the parathyroid hormone, this is a primary hypoparathyroidism. The parathyroid hormone is increased, and the phosphate within normal level, we look for the urine calcium. If it is increased, this is a primary hyperthyroidism. If the urine calcium decreased, this is a familial hypochloremic hypercalcemia. If the parathyroid decreased, we look for the parathyroid-related peptides. If it is increased, this is a hypercalcemia of malignancy. If the parathyroid decreased and calcitriol increased, this is sarcoidosis or lymphoma. If the calcidol is increased, this is a vitamin D intoxication. Hypercalcemia management, we identify and treat the underlying cause. We consider consulting endocrine or nephrology. In severe hypercalcemia and symptomatic, we rapid lower the calcium, start IV fluid with normal saline diabetic. We initiate pharmacotherapy with a calcitrine or biphosphate or dinsumab. We consider hemodialysis if refractory hypercalcemia. Hypocalcemia is the level of the calcium is less than 8.5, or the ionized less than 4. Severe hypocalcemia is that the level of calcium less than 7.5. The clinical feature of hypocalcemia, neurological manifestation, tetany, paresthesia, and stiffness or seizure, cardiac manifestation, congestive heart failure, hypotension, or cardiac arrhythmia. Manifestation of chronic hypocalcemia, psychiatric manifestation. We approach the hypocalcemia by looking for the parathyroid hormone. If the parathyroid is low and the phosphate is high, this is hypoparathyroidism. If the parathyroid increase, we look for the magnesium. If it is decreased, this is malabsorption or alcohol. If the phosphate is increased, this is pseudo hypoparathyroidism. If the phosphate increases, this is kidney disease. Therapy for hypocalcemia consists of calcium supplementation and the treatment of the underlying cause. Severe or somatic hypocalcemia, like tetany, seizure, prolonged QT, will start IV calcium supplementation 1 gram to 2 gram IV over 20 minutes. And chronic hypocalcemia, we will give a supplementation through oral medication, oral calcium supplementation, calcium carbonate 150 milligram BOD. Hypomagnesium is defined as the level of the magnesium is less than 1.5. Severe hypomagnesemia is less than 1 milli equivalent. The causes is alcohol, celiac disease, Crohn's disease, diarrhea, malnutrition. The clinical feature is anorexia, nausea, vomiting, muscle weakness, cramp, hyperreflexia, ECG. It will be long Q2 interval, and hypokalemia and hypocalcemia. The management will be through giving magnesium sulfate 2 gram IV of 510 1 gram IV every hour. Will be the serum magnesium after every dose, and we correct the other electrolyte imbalance. Hypermagnesemia is defined that the serum of magnesium more than 2.2 and the causes increase intake of magnesium, eclampsia, cardiac arrhythmia, laxative, decrease in magnesium, elimination, renal failure, hypothyroidism, adrenal insufficiency, case tissue breakdown, rhabdomyolysis, trauma, burn, surgery, cardiac arrest. The clinical feature is nausea, vomiting, blurred vision, muscle paralysis, reduced deep tender reflex, respiratory failure, bradycardia, and cardiac arrest. The management of hypermagnesemia will look for other electrolyte, renal function test, continuous cardiac monitor, discontinue all magnesium-contained medication, identify and manage all underlying disease. We will start IV fluid line with the loop diuretic for if the normal renal function. We can give 100 milligram of per milli calcium gluconate over 2 to 3 minutes in life-threatening hypermagnesemia. Hyperphosphatemia, the normal phosphate level is between 2.5 to 4.5. Hyperphosphatemia is that the level of phosphate more than 4.5. Severe hyperphosphatemia
دكتور اتصال تفضل معك مرة ثانية.
مشكلة شابك بالجوال ويجيني التصويت يطفي.
ما في مشكلة.
صوتي واضح كده؟
اي واضح.
The clinical feature is asymptomatic high phosphate level causes formation of insoluble calcium phosphate, which can lead to hypocalcemia and renal stone formation. The symptoms of hypocalcemia, paresthesia, muscle cramp, cardiac arrhythmia. The management of hyperphosphatemia, first we need to identify and treat the underlying cause. In severe hyperphosphatemia, we consider IV fluid with normal saline to renal excretion. Hypophosphatemia, that the level of phosphate is less than 2.5. Severe hypophosphatemia that is less than 1. The causes increase renal excretion, genetic decrease in absorption, vomiting, diarrhea, chemotherapy. Clinical feature, generalized muscle weakness, muscle pain, fatigue, altered mental status, seizure, and cardiac arrhythmia. The management, we need first identify and treat and manage the underlying disease, discontinue, reduce contributing medication, phosphate supplementation. 1 millimole per kg IV over 4 to 6 hours in severe hypothermia. Now the fluid imbalance management. First, we need the diagnosis of fluid imbalance. We look for the physical sign for the skin, edema, the mucous membrane, neck vein, pulse, liver, level of consciousness, capillary level. And we look for the vital sign, the blood pressure, heart rate, and body temperature, CVB, urine output, serum and urine sodium, osmolarity, serum and serum total protein. Dehydration, the sign of dehydration in mild dehydration, that the skin decrease in the skin trigger, the sunken eye, dry mucous membrane. In moderate, oliguria, orthostatic hypotension, tachycardia. In severe dehydration, the patient has hypotension, decrease in level of consciousness. In the dehydration is classified according to the osmolarity. Isotonic dehydration, intracellular fluid volume remain constant, extra renal loss like vomiting, diarrhea, hemorrhage, or burn, internal loss, alias, ascites, pleural effusion. The therapy for isotonic dehydration, volume replacement with isotonic solution. Hypertonic dehydration, extracellular and intracellular fluid loss, and elevated osmolarity. The causes, inadequate replacement of hypotonic fluid loss, osmotic diuresis like in diabetes, decrease in ADH secretion, high fever, heat stroke, massive diarrhea. the therapy for hypertonic dehydration, slow water replacement. Hypotonic dehydration decrease the extracellular fluid volume and elevate intracellular fluid volume. Causes adequate fluid replacement with hypotonic solution, elevated ADH secretion, extracellular fluid loss, Addison disease, diuretic, and vomiting. Third, isotonic fluid replacement, sodium replacement in case of severe hyponatremia. Hyperhydration sign is edema, increased skin trigger, elevated CVB, distended neck vein, pulmonary edema. And also classified according to the osmolarity, isotonic hyperhydration, intracellular fluid volume remain constant, causes renal failure, heart failure, decrease oncotic pressure, increase isotonic fluid intake. Therapy, decrease intake diuresis, decrease intake and diuresis. Hypertonic dehydration, the causes is renal failure, excessive hypertonic fluid input, increased thirst, fever, convulsion. Therapy, dialysis, slow replace with hypotonic solution. Hypotonic hyperhydration, intracellular fluid volume is also increased, water, like in water poisoning, causing heart failure, near drowning. The symptoms will be weakness, nausea, vomiting, altered mental status. The therapy will be diuretics plus full fluid replacement with isotonic solution. This is the end of my presentation. I'm sorry for the interruption. And if you have any question, ready.
Any questions, Dr. Salam? طيب راح نبدأ إن شاء الله بالكوزز. I'll give you 2 to 3 minutes to solve the quiz. Assalamu alaikum. Is my voice clear? So we started the quiz after the presentation. طيب يعطيكم العافية. Again 50% participation. يعطيك العافية دكتور سالم for your presentation. It's very difficult to try to explain, not to explain, but to rather give a lecture on electrolyte, biochemistry or anything related to that to cardiac cells. يعطيك
بسرعة
العافية.
شلت الكويز
Sorry.
بسرعة شلت الكويز.
طيب معلش. We give around 3 minutes. That's usually what we're gonna try to give. طيب, first question is findings of hyperkalemia in ECG. Um, there's diversion around 50% of the people answered peaked B wave, and the majority answered B wave widening and flattening. Probably you're confusing between peak T wave, and that's the classical sign that we see or we learn in books and everywhere that this is the sign of hyperkalemia. Peak T wave and not B wave. Usually the B wave, this is less common or less common knowledge to people, is the B wave widening and flattening with PR prolongation. T wave flattening is usually wrong. It's the opposite. T wave peak and AVNRT is relevant. Second question is diuretic usually leads to the following electrolyte imbalance. I need to admit that this is the wrong question on my behalf. The question should have been Lasix usually leads to the following electrolyte imbalance. However, majority of you, around 80% of people answered the correct answer, which is hypokalemia and hypomagnesemia. If you remember, Lasix affects the NAK chloride co-transporter and it inhibits it. Therefore, you have the main effect is hypokalemia. However, hypomagnesemia reabsorption is also affected because of the change of electrolyte concentration of the renal tubules. So answer is hypokalemia and hypomagnesemia. Last question is hypocalcemia and ECG. Calcium alterations and imbalances are very rare to see, and we're less familiar with it. We usually almost never see it, for me, at least. However, you still need to know it, and you need to know the findings, especially for exams. And the answer is QTC prolongation. Hypercalcemia leads to the opposite, which is QTC shortening. Majority of you answered these questions correctly. يعطيكم العافية all. We'll try to take a break of 10 minutes and then we'll start with the third lecture, acid base imbalance. I'll start with I'll put up the survey and you can answer it meanwhile. Dr. Farid, any feedback regarding the lecture or the topic of electrolyte imbalance?
It's a very complex topic, especially if you're taking care of those patients after surgery in the ICU. I'd like to encourage you to attend a course by it's called Fundamental Critical Care. There is Fundamental Critical Care also specified for surgeon. I don't think there's any courses in the kingdom yet. There are only 2 or 3 people who are certified in that, as far as I know. There will be, though, in Mecca, there will be a course for FCCS. If you manage to register there, it's free for resident. So you may want to try to reach them and see if they, I think it's going to be in the first week or 2 of November. Other than that, I think it's knowing the details of electrolyte imbalance, especially preoperatively, taking care of your patients will avoid a lot of complications. The lecture was extensive, but I wish there were some scenarios that will be related to cardiac patients. Thank you.
Doctor. Please feel free to fill the survey for the presenter. السلام عليكم مستر نور دكتور جاهزة إن شاء الله؟ هم؟
جاهزة يعني.
بس صوتك شو ممكن
ما
صوتك
هو
واضح شوية.
طيب I'll try. لو ما هو واضح ولا شيء وقفوني.
خلاص يعطيك العافية، كذا بعطي 1 minute بعدين يكسر.
طيب. السلام عليكم. My name is Dhikra Khalaf and I'll be presenting acid-base balance. A quick overview of the ABG. ABG has a pH and partial pressure of the CO2, partial pressure of the O2 and saturation, base excess and electrolyte. Now, what's our goal when we see an ABG? First thing is to know, is it acidosis or alkalosis? And then to know, is it metabolic or respiratory? And then to know, is it fully compensated, partially compensated, or uncompensated? The physiology of the pH. So basically here we have the CO2 with the water. Through an enzyme called carbonic anhydrase, it will turn into carbonic acid. This carbonic acid is very weak, so it will divide into hydrogen ions and bicarb. What we care about the most here is the CO2 along with the bicarb. The normal pH from 7.35 to 7.45. And to calculate your pH from the hydrogen ions, we use the Henderson-Hasselbalch equation, which is very complicated. We don't use it nowadays. We use the modified version of it, which says that the pH equal to bicarb over the partial pressure of the CO2. Acidosis versus alkalosis. In acidosis, we have increase in the proton production, which is the hydrogen ions, leads to more acidic in the blood. That will lead eventually to acidemia, where the pH is less than 7.35. Alkalosis, when we have the opposite, decrease in the production of the hydrogen ions, which will lead to elevation of the pH to more than 7.45, which is called alkalemia. Now, the partial pressure of the CO2 is a measurement of the CO2 in the blood. It's basically regulated by the lungs. Normal value of it is 35 up to 45, and the primary problem is respiratory. For the bicarb, it's regulated by the renal system. Normal value of it is 22 to 26. Primary problem is metabolic. The partial pressure of the O2 is measurement of oxygen in the blood and the status of the oxygenation in the tissues. Normally, it's decline with age. So age less than 60, the normal range is 85 to 100, and age more than 60, normal range is 83. Saturation is what we all know, is the oxygenation saturation in the blood, which is normally 95%. Base excess is that what we need to correct our pH and return it into normal or near normal values, which is +2 or -2. And the electrolytes we have in the ABG, that's the sodium, potassium, and chloride, and these are the normal values of it. Now, it's very important to know the anion gap, because in case of metabolic acidosis, we have to know, is it normal anion gap or high anion gap? How to calculate the anion gap is to subtract the extracellular ketone, which is the sodium, from the chloride and the bicarb. The remaining amount represent our anion gap. Now, to say this is normal anion gap, it has to be less than 12. In shortcut, we call it NAGMA. And the high anion gap, it's more than 12. Shortcut, I'll call it AGMA. Now, the steps to read your ABG is to look first at the pH and to know, is it acidosis or alkalosis, and then to look at the bicarb to know the primary disorder, and then to calculate your anion gap to see, is it normal or high anion gap metabolic acidosis, and then to evaluate the compensation mechanism, and then to apply what you found in the ABG and correlate it with the signs on the clinical examination. This is the bulk of my presentation, which is the acid-base balance. We have metabolic alkalosis, metabolic acidosis, respiratory alkalosis, and respiratory acidosis. Starting with the metabolic acidosis, this is where the pH is low, bicarb will be low, CO2 will be normal or unaffected. I'll start explaining first the anion gap metabolic acidosis causes. This is when the anion gap more than 12, as I've already mentioned. First cause is ketoacidosis. This is when the body deprived from the glucose, so it uses the storage, the energy storage we have, which is the adipose cells, breaking it into triglyceride, into glycerol and fatty acid. Now, the fatty acid break down through the beta oxidation to acetyl-CoA, which eventually give ATP and ketone bodies like acetoacetate and BHB along with the acetone. Acetone can turn into gas, and this is what we smell in patients at the presentation on their breath. The causes could be diabetic or alcohol or starvation. In diabetic patients, especially patients with the type 1 diabetes, because they don't have insulin, the role of insulin is to inhibit the beta oxidation, preventing the whole outcomes of the ATP and the ketone bodies. So we don't have it now. There is no utilization of the glucose due to the absence of insulin. In alcohol patient, there's diminished in the hepatic gluconeogenesis that will lead to decrease in the insulin secretion, and that will increase lipolysis, and then will lead to impaired shifting or shunting of the fatty acid into the mitochondria. And instead of that, the fatty acid will go through the beta oxidation, leading to same outcomes of the ATP and the ketone bodies. Starvation, decrease in glucose, will eventually lead to stimulation of the glucagon and lipolysis. Second cause is uremia. This is when your kidneys is unable to filter the waste products like phosphate, urate, and sulfate. This accumulation of these substances will increase the ability of the release of the hydrogen ions, which in turn will lead to acidosis. Now, lactic acidosis as the third cause. This can happen to three main things: either increase in production, or decrease in clearance, or hypoxia. And it's divided into two types, type A and type B. For type A, oxygen is an important element for a production of the ATP from the Krebs cycle by turning the glucose to pyruvate through the glycolysis. Now, when in case of hypoxia, we don't have the oxygen, so instead of turning the pyruvate, when we don't have, in case of hypoxia, when we don't have the oxygen, the pyruvate will convert into lactate instead. Example of this, patient with anemia or embolism or lung issues like COPD. Now, type B, there's decrease in the clearance in case of liver or renal failure, or increase in production. Example for this is a medication that's going to inhibit the oxidative phosphorylation, like, for example, propofol, metformin, propylene glycerol, what means that is benzodiazepine. Now, the inhibition of the oxidative phosphorylation is always combined by elevation of the glycolysis. That will result in increase or enhance the glucose consumption and lactic acid production. Increased glycolysis, like patient with malignancies, for example, leukemia or seizures. Toxins that include methanol, and ethanol, propylene glycol, along with salicylate. Other causes, now we finished the causes of anion gap metabolic acidosis, moving to the second part, which is the normal anion gap metabolic acidosis. That means that the anion gap is less than 12. For example, if you're overcorrecting a patient, we're giving too much normal saline and hypertonic saline for a long duration and high volume, that will lead to elevation of the chloride, which in turn decrease the bicarb. Acetazolamide, this is carbonic anhydrase inhibitors, works on the renal tubules, causing them to lose more bicarb. Renal tubular acidosis, we have the three types of them. Type 1, the problem in the distal tubules, where we have decrease in the hydrogen excretion and hypokalemia. Type 2, in the proximal tubules, where we have a decrease in the reabsorption of the bicarb and hypokalemia. Type 4 is distal tubules will be affected, or in other words, unresponsive to aldosterone. That's why we will have decrease in the hydrogen excretion and hypokalemia and hyponatremia. Diarrhea, diarrhea, we will lose the bicarb from the GI tract. Sorry. The remaining two causes is the ureter diversion. This is a procedure used in patients with the bladder cancer that will lead to loss of the bicarb through the stool. Pancreatic fistula, when we have abnormal connection between the pancreatic ductal epithelium and another epithelium surface, that will lead to a loss of bicarb from the GI tract. Now, how to compensate this? Through respiratory. The respiratory compensation for metabolic acidosis. So we basically have decrease in the bicarb. The lungs want to compensate this by decrease the CO2. So reduction of the partial pressure of the CO2 1.3 per 1 milliequivalent decrease in the bicarb. Second thing is metabolic alkalosis. This is when the pH is high, bicarb will be high, the CO2 will be unaffected. Okay, the pathophysiology of it, or the causes, we can divide them into saline responsive and saline resistant. For the saline responsive, patient with excessive vomiting, there will be a decrease in the HCl absorption by the GI, which will lead eventually to loss of bicarb. Diuretics, especially loop diuretics, there will be excretion of the sodium, potassium, and hydrogen ions that will lead to alkalemia. Chronic respiratory acidosis, like patient with severe COPD, because we have a high or increase in the CO2, our lungs is not able to wash out all the CO2. So the renal compensation will be by increasing the bicarb, which eventually will lead to alkalosis. Saline resistance, we have three main causes. Cone syndrome, because we have high aldosterone, and the aldosterone works on absorption of the H2O and the sodium and excretion of the potassium and the hydrogen. That will lead, any loss of the hydrogen will lead to alkalosis. That's why we have alkalosis. Now, it's very important to know the aldosterone mechanism of action, because in the next two causes, one of them is similar to aldosterone effect, and the other one, the end result of it is aldosterone. For example, the renal artery stenosis, because we have low blood flow, that will stimulate the angiotensin II to release aldosterone, and that eventually will lead to excretion of the potassium and the hydrogen, and end result will be alkalosis. Cushing syndrome, similar, or we have high level of cortisol that mimics the aldosterone effect, leading to the same outcome of increased excretion of the hydrogen ions and alkalosis. Now, the respiratory compensation for the metabolic alkalosis is the opposite to acidosis. Now we have increase in the bicarb, so we want to increase the CO2 in order to correct our pH. The compensation, increase in the partial pressure of the CO2 0.7, equal to 0.7 per 1 milliequivalent, decrease in the bicarb. Third thing is the respiratory acidosis. Now we have the pH is low and the CO2 is high. Our lungs is unable to wash out all the CO2. That's why the pH will be low. The respiratory acidosis result from pulmonary or extrapulmonary disorder that can cause hypoventilation or hypercapnia. Two types, we have acute and chronic respiratory acidosis. Now, each one of them have different causes. Causes for chronic respiratory acidosis, like acute pulmonary edema, obesity, pulmonary fibrosis, along with asthma and COPD, or a neuromuscular disorder. Now, to summarize them all for a better understanding, we can just put them into anything that will affect our lungs' capacity to wash out the CO2. That we can divide them into CNS causes and neuromuscular disorders and obstructive lung diseases. Acute respiratory acidosis causes, we have emphysema, sleep apnea, pneumonia, asthma, COPD, or any substance that affect the central nervous system, like alcohol, amphetamines, or opioids. Now, the renal compensation for respiratory acidosis. Now, we have increase in the CO2. In response for this, we want to elevate the bicarb. So the range of compensation is different from acute to chronic. In acute cases, increase in the bicarb by 1 milliequivalent per 10 increase in the partial pressure of the CO2. In chronic cases, increase of the bicarb by 3.5 milliequivalent per 10 increase in the partial pressure of the CO2. Final thing is the respiratory alkalosis. Now, the pH is high, the bicarb is not affected, and the CO2 is high. So our lungs is doing completely the opposite of the previous slides. So it's basically washing out all the CO2 inside the lungs to out. The pH will be high. So as I've said, overdrive the respiratory system leads to washing out the CO2, which in turn leads to increase the pH. Now, the causes can be divided into hypoxia, like people who live in a high altitude, hypertension, severe anemia, or CNS mediated like infection, trauma, or tumors, or voluntary hyperventilation, or an anxiety hyperventilation syndrome. Pulmonary diseases that can include PE, pneumonia, interstitial lung diseases, or mechanical overventilation when we overventilate the patient and washing out the CO2 from the lungs, and that will lead to increase in the pH. Then renal compensation of respiratory alkalosis, we have low CO2, so we want to compensate this by decreasing the bicarb. The compensation is different from acute to chronic. In acute, we have decrease in the bicarb by 2 milliequivalent per 10 increase in the partial pressure of the CO2. In chronic, we have decrease in the bicarb by 5 milliequivalent per liter per 10 increase in the partial pressure of the CO2. This is a very nice table that's summarizing pretty much everything I've said, starting with the disorder and the primary defect, and then the compensatory response. In patients with respiratory acidosis, either acute or chronic, both of them, we will have primary defect, elevation of the CO2. And then the compensatory response, we will elevate the bicarb in order to normalize the pH. And now we have the respiratory alkalosis, acute and chronic, both same. We will have decrease as a primary defect, decrease in the partial pressure of the CO2 and decrease in the bicarb. Metabolic acidosis, we will have decrease, the primary defect, decrease in the bicarb, and decrease compensatory, we will have decrease in the partial pressure of the CO2. In metabolic alkalosis, we will have as the primary defect increase in the bicarb, and as a compensatory mechanism, we will have increase in the partial pressure of the CO2. Now, the effects of what actually the acidosis and alkalosis do to the body, or what's the effect of them on the body. Starting with the effect of acidosis on the body, on the heart, the acidosis will decrease the contractility. That will lead to decrease the stroke volume. And in turn, that will lead to decrease the cardiac output, and overall end result will have low mean arterial blood pressure. So that will also acidosis have also effect on the peripheral resistance, leading to dilatation. So the dilatation will lead to decrease in the resistance, which further decrease in the blood pressure. The end result can be hypotension and sometimes shock. The effect of acidosis on the heart rate, it will increase the heart rate, leading to fatal arrhythmias like VTAC. Pulmonary effect of acidosis, because we want to wash out all the CO2, we will increase our respiratory rate, and over time that can cause fatigue and muscle weakness, because we keep on using our accessory muscles in order to wash out all the CO2 inside. Metabolic status, we have hyperkalemia and insulin resistance. CNS effect of acidosis, altered mental status, and coma. Effect of alkalosis on the body. Now, on the heart, alkalosis cannot do much on the contractility, or it's not actually affecting the contractility of the heart, but it's affecting the total peripheral resistance, leading to arterial vasoconstriction. The heart rate will increase in alkalosis, same as acidosis, leading to VTAC, VFib, or even SVT. And pulmonary, because we have alkalosis, we want to keep all the CO2 inside, so we will have decrease in respiratory rate, and this will lead to hypoxia. Metabolic status lead to hypokalemia, hypomagnesemia, and hypocalcemia, CNS, altered mental status, and tetany along with coma. Now, this is a very nice summarization for all the presentation. You have your ABG, you have to look at the pH. Is it more than the normal or less? If it's less, then you go for acidosis, and then you have to know your primary disorder. Is it metabolic or respiratory? And then you have to look at the compensation mechanism. If it's more, the pH is more than the normal, you go for alkalosis, and then you have to know, is it respiratory or metabolic? And then you see the compensation mechanism. Thank you. That's it for my presentation.
شكرا يعطيك العافية دكتورة ذكرى. Excellent presentation. You summarized almost everything. And this one tip regarding acid-base disorders. Acid-base disorders, usually any presentation on them to the audience is easy initially, but once you bring examples, all the holes within their understanding comes up. And it's usually best explained in such way by putting a lot of exercise, a lot of examples and questions. بس يعطيك العافية. Very excellent thorough examination. Presentation. Any questions to Dr. Dhikra or feedback? If not, we'll start with the quiz. السلام عليكم يا جماعة، الكويز طالع لكم ولا لا؟
لا ما طلع.
أنا طالع لي في
واضح وليد.
ابتسام. if anyone is using a phone to access the presentation or Zoom, quizzes, if you miss it initially, on top on the left في record و live و there is كذا زي الجراف. لما تضغطون على الجراف it will open two options for you, الريكوردينج والquizzes in progress. فيوريكم انه الكويز running or no. And the quiz, if anyone is asking, usually below, جنب البارتيسيبنت والchat, if you go to the end more, you'll find polls and quizzes. If you click on it, you'll see the quiz. تمام، يعطيكم العافية. So we'll move on to the questions. The first question is just a simple acid-base disorder and giving you the values and answering. دكتورة ذكرى،
Yes.
ممكن since you already explained the topic and I'm sure you're aware of this, but if you would to go through reading this ABG, how would you read it?
Yeah, I don't have the question, okay?
Hold on, I'm showing it now.
First question, right?
Hey, first question.
So the pH is lower than the normal.
ممتاز. Which indicates what, acidemia or alkalemia?
And then the CO2 here is within normal and the bicarb is low. It goes with metabolic acidosis.
ممتاز. Do you have a way of يعني going through the results ولا usually?
What do you mean?
يعني what do you look at first? What do you look at
To
bicarb, huh?
I look at the pH first to determine is it acidosis or alkalosis.
Mhm.
And then I
And then-
look in this example, the next one is the CO2. I will see if is it within the normal range or lower or higher. And then I'll look at the bicarb. Is it lower or higher than the normal range?
ممتاز. يعطيك العافية دكتور. طيب, second question is what is true about compensation in acid-base disorders? And here we have a lot of answers. The first answer was metabolic compensation is usually one second, let me just open it. So is metabolic compensation, there is usually rapid process that takes minutes for response and is complete within 12 to 24 hours. Usually the metabolic compensation takes much more than that. We're talking about days. So if you have a primary respiratory process, you'll have a metabolic compensation, but that will take time to show itself. That's why in respiratory acidosis or alkalosis, usually the algorithms that you see for compensation will diverge into either you have acute respiratory disorder or chronic, which you don't have in primary metabolic disorder. So that's wrong. The second option is the usual compensation is dependent on the initial imbalance and it's reverse in direction and type. And Dr. Adhikra explained this nicely in the schedule that he showed. Usually when you have, for example, respiratory acidosis, you'll have something completely in reverse in direction. And so direction, which means the pH is gonna be on the opposite side. So respiratory acidosis, you'll have alkalosis, and the type respiratory, the opposite is metabolic. So for respiratory acidosis, what you'll see is metabolic alkalosis. So that's the correct answer. Compensation always returns the pH to normal? No, that's usually actually it doesn't return it to normal. If the pH returns to normal, sometimes that can indicate a secondary metabolic disorder. Last option is consistency with the predicted compensatory response indicates the presence of another acid-base disorder. And that's wrong. Inconsistency with the predict. So for example, if you have metabolic acidosis and then you calculate the predicted CO2, if you have, for example, the predicted CO2 to be, for example, I don't know, 20, if you have CO2 of 40, that's inconsistent with your calculation. And it goes toward the acidosis. So that usually means you have metabolic and respiratory acidosis. And that's the point of confusion in a lot of ABG questions, the calculation of the compensation and understanding the meaning. So just know if it's inconsistent, it means there is something wrong. If it's consistent, خلاص, you only have one primary and the compensation that is normal. Last question is an example of a patient with multiple acid-base disorders. I made now that I'm noticing that the question is very easy since once you pick up the primary disorder, خلاص, you can pick up the secondary. The ABG is showing patient with respiratory acidosis, and none of the other answers are showing is respiratory acidosis. But how would you go about this question if you have it in an exam? You can see that the pH is 7.3, which indicates acidemia. The CO2 is high, 65, which indicates respiratory process. The CO2 is high. Now you need to calculate the the bicarb. Again, if it's consistent, then that's it. You only have one disease. If you have inconsistency, that means you have mixed. The CO2, the bicarb, if you actually calculate it, it's gonna be, I think, around 26. And since the CO2, the bicarb is more than the number you have, bicarb, once it increases, it means you have alkalosis problem. If it decreases, acidosis problem. So it's more than your calculation. That means there is metabolic alkalosis. That's why you get the third option. Anyway, I hope our presentations and the quizzes and all the changes that we have made so far were beneficial to your experience with the activity. Before we end, I would like you to answer the survey. And meanwhile, Dr. Farid, do you have any feedback or questions to the group or to the presenter?
Yes, a comment about how to master this skill of IBG's understanding and interpretation and recognition of disease. First, you have to know acidosis is a very bad ominous sign for cardiac patients. Anytime you have acidosis, it's a bad sign, and you should be able to recognize it. One of the pH is not the only one, but also the lactate should be on your list. And of course, you should take actions immediately before the patient reaches the stage of arrest. How to master this skill? If you make it a habit from day one, as you go in the morning before going to, as you go in surgery, check the patient's first ABGs. That will tell you usually how sick is the patient's preoperatively. Check the immediate ABGs done in the ICU for this for that patient, and that tells you how good our procedure was, perfusion, etc. And then after you finish your second case, surgical case, go back again to the ICU and look at the third ABGs. That will be maybe a few hours, 4 hours later or so. And try to read it, interpret it every time. If you do that during the 7 years program, you will have more than easily 2,000 read of ABGs. And that can be very instrumental in developing your skill of interpretation and understanding this. It takes only, less than a few minutes, 5 minutes, like what your colleagues have explained, looking at the pH, looking at the CO2, looking at the bicarb, and the lactate. Good luck. Thank you.
So just finish answering the quiz, and that's the end of our activity. I hope you all a nice weekend. And thank you for all the presenters, Dr. Yusuf, Dr. Dhikra, and Dr. Salim.
Very nice organization, yeah, Waleed. I like the way you put the questions, and I'd like also the presenters and their presentation. I think this, I'm sure this is all, it is a teamwork from you and Dr. Muhannad and others. So keep up the good work. Thank you.